Hi, everybody. This is Steve Simpson, and this is the Midwest Critical Care Collaborative. And of course, you couldn't beat that timing, could you? Um, we Midwest Critical Care Collaborative meeting for May 14th of 2015, and I think we are ready to go ahead and get started. I think all of you who are on saw my email that what we intend to talk about today is a recent article in the New England Journal of Medicine. I think March 27th no, April 23rd was that article discussing the importance, or in their eyes, lack of importance of SIRS to the diagnosis of severe sepsis. And I think that's an interesting topic, and we'll need to decide moving forward what we believe about the data that they present. And so I thought it would make a nice thing to talk about. Unfortunately, Lee Tolman has another commitment today and can't be with us, and I'm very seriously interested in hearing what Lee has to say, because he has worked extensively in this area as well. But I think I'm interested in hearing what everybody has to say, and at least it should engender some questions as we move forward. So let me take this puppy and put it up. So SIRS and sepsis is our initial topic, and then assuming that we have plenty of time for discussion, we'll talk some about longer-term outcomes and implications for the healthcare system in and around severe sepsis. But the key thing is I want us to discuss this topic about SIRS, sepsis, and long-term outcomes. So the article we're going to talk about was this one, the Systemic Inflammatory Response Syndrome Criteria in Defining Severe Sepsis. It was published, as I said, in the New England Journal of Medicine on April 23rd. And it was performed by the investigators of the ANZICS, and you've heard that before on this particular webcast, us talking about ANZICS and some contributions that they have made to the literature. ANZICS stands for the Australia and New Zealand Intensive Care Study, and they do study prospectively everyone that's admitted to their intensive care units. So they have collected a lot of data, and they are making good use of it with this particular study. So what they were interested in, I should have put up their hypotheses, but their hypotheses are rather hoity-toity sounding, and we'll come back to that later at the end when we talk about whether they address their hypotheses and what they might mean. But they're just, well, actually, I'll go ahead and state that their hypothesis was the two or threefold. One, that the face validity of SIRS is not there. Number two, that the construct validity of SIRS is not there. And number three, that there's nothing special about the cutoff point of two or more SIRS criteria that should make it a particular cutoff point or a thing to shoot for. So this was a retrospective analysis of all of the data in their Australia and New Zealand database, the ANZICS database. SIRS was defined in the normal way, just like we're all used to defining it, and I don't think I need for this audience to go into that. By the way, one second, I'm going to get my pointer so it remains arrow, so it remains up all the time. And organ dysfunction, in slightly different than what we might use, they defined organ dysfunction by the SOFA score. And SOFA score is a validated tool, stands for Sequential Organ Failure Assessment Score. And it's just a little bit different from what we're used to doing. My assumption is that they did this because they have calculated SOFA scores and input them in the database on everyone in their intensive care units. So, what did they find? They studied data from 1.17 million patients in 172 ICUs. This is over the course of about 12 years. total of 1 million did not have sepsis, but 109,663 had infection and organ dysfunction. And that was their definition for severe sepsis, by the way. And then they separated into SIRS positive severe sepsis and SIRS negative severe sepsis. So out of those patients with infection and organ dysfunction, 87.9% had SIRS and 12.1% had SIRS negative, meaning they had only 1 or 0 SIRS criteria during their diagnosis. So that's good. I mean, this is the methods section, of course, in the New England Journal is a little more complex than what I just showed you, and it talks all about the statistical evaluations and etc. But so I just thought I'd display up their table. So here on this table and the next one, we have all patients with severe sepsis down this column. We have SIRS positive down this column and SIRS negative down this column. Something that you will note here, well, actually, let's just start going down the list at the different things. So ages were slightly different, with the SIRS positive age people being about 3 years younger on average than the SIRS negative. There were slightly more males than females in the SIRS negative than in the SIRS positive. You were more likely to have been admitted for a surgical problem in the SIRS negative sepsis, which I find interesting because one of our complaints from surgeons often is everybody has SIRS. Well, apparently that isn't exactly the case based on this analysis. And your Apache 3 score is substantially higher in the SIRS positive sepsis than in the SIRS negative, meaning that overall you are a sicker, higher mortality population in the SIRS positive. Let's see, Apache 3 score, the medians. Yeah, so again, they're just trying to show here that the median Apache 3 is substantially lower in the SIRS negative than it was in the SIRS positive. ANSROD model we're not going to go into. It's basically a similar to Apache 3 model that they use in Australia and New Zealand that they say in their own patient population performs better than Apache 3. ICU length of stay is longer for the SIRS positive folks than the SIRS negative, and hospital length of stay is 2 days longer in the SIRS positive than it is in the SIRS negative. Treatment limitations, i.e. how many people went palliative in this, slightly more in the SIRS positive. And here's something I'm going to point out here, but you will also see is true in some of the other large studies we look at. When you start talking 96,000 patients in one group and 13,000 patients in the other group, differences that are actually pretty small, 1.7%, show up as highly statistically significant. Whether there's a true clinical difference there or not is difficult to say, but statistically speaking, it's easy to show small differences when you have great big numbers in your groups like this. So mortality rate, again, higher with SIRS positive sepsis than SIRS negative. Discharge to home, less likely with SIRS positive than SIRS negative. Rehab or discharge to another hospital. My presumption is this discharge to another hospital is LTAC. Although I don't know that because they don't specifically spell it out. Just that I think in general you don't consider it discharge to another hospital pretty much unless you are going to a long-term acute care facility. So if you were positive for SIRS, you're more likely to have, yes, you're more likely to have had shock if you are positive for SIRS. You're more likely to have been slightly less likely to have been mechanically ventilated. You are more likely to have had acute renal failure, and you have a higher Apache 3 score. So all of these things. So SIRS portends several things there. So then they went, let's take a look just for fun to see which SIRS criteria were people more likely to have. And so the commonest, if you were in the SIRS positive group, so in other words, if you're going to have 2 or more, the commonest is abnormal temperature. But that isn't the case in the SIRS negative group. In the SIRS negative group, the single most common SIRS criterion that anyone expressed was tachycardia, which was actually, I guess that's the single most common. I apologize. That is the single most common. Oh yeah, now I remember from the text. Heart rate and respiratory rate are the most common presenting features in both SIRS positive and SIRS negative. Abnormal white count, much more common in the SIRS positive than in the SIRS negative, which is very interesting. So this is the distribution in your SIRS positive folks. 2 were present in 27% of the folks, 3 were present in over 40%, 4 were present in 30%. So actually, if you're tending to be SIRS positive, this is fascinating, that well over half of people who are going to be SIRS positive, in fact, 2/3 of people who are going to be SIRS positive have 3 or 4 SIRS criteria, which I find interesting. About 20% of the people who didn't have SIRS had 0 criteria. The remaining had 1 criterion, and as we saw up here, the single commonest was increased heart rate, but there was a pretty good distribution across all the different SIRS criteria in the no SIRS group. So, unadjusted annual mortality looks like this. In the SIRS group, mortality is higher, which is actually interesting because I personally would not have predicted that the SIRS group was going to have a higher clearly lower mortality in the no SIRS group. But the other thing that's important about this, notice this, we've talked about this in previous months too, that over the course of time, the mortality rate for severe sepsis is going down. Between 2000, where it was up around 37%, down to 2013, where it's down around 20%, steady decline in the mortality rate. However, you may remember from previous talks that we've had and the ANZIC's own study group that although the mortality rate's going down, the absolute number of cases is going up. So there are actually more deaths from severe sepsis now than there were in 2000. Your odds, adjusted annual odds of death, not particularly different between, with this as the baseline, not particularly different between the SIRS and no SIRS group, meaning that regardless of which you had, your annual risk of dying is going down, and it's going down at approximately the same rate in both groups, which is, you can approximate that again by the slope of these two curves here. So that's what we see. Where did people go after they had sepsis? If you were positive for SIRS, you were actually, I'm sorry, that's not quite what this shows. This is the change in where you went between 2000 and 2013. So, in other words, if you were going to be discharged to, you're slightly more likely to be discharged to home in 2013 than you were in 2000. or to a long-term care facility, you're more likely to be discharged to a long-term care facility now, than you were in 2000. That's the whole point here, and that's the case in both SIRS positive and SIRS negative. And this is if you are discharged. That's the key thing. What's the denominator here? The denominator is people who were actually discharged. So if you were discharged, you are more likely now to go to a rehab facility than you were in 2000, which is of interest, I think. And I'm not quite sure how to interpret that. So here's the other thing. Remember, one of their hypotheses was that the number of SIRS would correlate with the outcome, and that's exactly what they did show, which is if you had 0 SIRS, here's your outcome, 1, 2, 3, 4. So spanning all 4 SIRS criteria, regardless of what combination of 2 or 3, or, well, if you have all 4, there's only one possible combination for that. But regardless of what your 1 or your 2 or your 3 are, your mortality risk is higher the more SIRS that you have. And again, so they show the adjusted odds of death. If this is no SIRS, so compared to no SIRS, you are substantially more likely to die with each additional SIRS criteria that you have. So that kind of proved one of their points. They said, we think there should be a linear correlation between the number of SIRS and the mortality, which does exist. And they also suggested, we're not sure there's anything special about 2 SIRS over 1, or 2 SIRS that isn't there for 3 or 4. Why should 2 SIRS criteria be the cutoff as far as making a diagnosis? So their conclusions that SIRS is not necessary for one to have severe sepsis. 2 SIRS doesn't seem to be a cutoff for anything. And then this issue of face validity versus construct validity. So face validity and construct validity, it's highfalutin ways of saying this. They said up front, we don't think there's face validity. What does that mean? Face validity, if you look it up and delve into it, means that if you look at a test, to the untrained observer, do they believe that the test does what it's supposed to do? So for us, that would mean to the untrained observer, do they look at SIRS and think that SIRS is giving them useful sepsis information? Well, these authors said that it had no face validity, but I think that's a purely subjective judgment. And so I think it probably shouldn't even have been included in the study to make conclusions about face validity around this. There have been arguments since 1992 about whether SIRS is exactly what we need. Is it precise enough? Is it specific enough? Is it sensitive enough? Etc. And so we know that it's not a perfect discriminator of anything, and we have known that for quite some time. So if an author says there's no face validity to it, it means just basically they have been on the side of the fence that they don't like SIRS from the get-go. Construct validity, on the other hand, is a different logical concept, and what it means is, does the test actually tell you the information that you are interested in receiving once the test is performed? So their conclusion here is that they think that there is no construct validity to our current criterion of 2 SIRS or more to diagnose severe sepsis. And the reason they say that is because the mortality, as they showed, was actually higher even if you only have 1 SIRS than if you have no SIRS. So they say that this basically isn't a particularly valid thing to use for anything. So what conclusions should we draw? Number one is, when I first read this paper, I went, well, this is a bit of a non sequitur, because SIRS never has been an absolute requirement for the diagnosis of severe sepsis. In fact, many of you may have asked me, and I certainly have been asked dozens of times over the course of the years, so what do we do with this patient who has a pneumonia and doesn't have tachycardia, tachypnea, fever, or high white count, but does have acute renal failure? And my answer is, and always has been, that then is severe sepsis, because the key underlying feature that we are looking for is the presence of organ dysfunction to define severe sepsis. This is why the Derek Angus's criteria, on which a lot of our epidemiology of severe sepsis is based, from his 2001 study, where he looked in the hospital across the nation for the presence of an acute infection and an acute organ dysfunction. This is why his criteria work, and resulted in a population that had about a 25% risk of dying in his study, is because organ failure is the key defining factor for severe sepsis. Which basically, actually, the interesting thing about this article is they assumed that organ failure is the key defining factor because their no SIRS group, they said, had severe sepsis based on having an infection and an organ dysfunction. So they're sort of arguing against a criterion that they themselves don't believe or use. So is there any usefulness to this? As I said, we've known for years that the absence of SIRS does not eliminate you from being diagnosed with and or having severe sepsis. So did they add anything to the literature with this? And I have to sit back and say this. Over the course of my 30 years in medicine, I've read numerous articles where the conclusion drawn was sort of a no-brainer, where, as a matter of fact, the study that was done was sort of a no-brainer to answer a question that, in my mind, didn't exist. And this is that sort of a study. In my mind, there is no question that whether you, even if you don't have SIRS, if you've got organ dysfunction, you still have severe sepsis. That was never a question. That was never a question in Roger Bone's mind, and he's the progenitor of these criteria, or was the progenitor of these criteria. So this is a question that I would have never thought to ask. And so this becomes one of those studies where you go, gee, I wish I had asked that, because they got to publish in the New England Journal of Medicine by answering a non sequitur, so to speak. So does this mean that we should discard SIRS? This is what I'm going to toss out for discussion. And what should the ongoing role of SIRS be in the diagnosis of severe sepsis? So before I toss it out, I guess it's fair for me to state my own opinion about this. So first, we start with the premise that you don't have to have SIRS to have infection. Secondly, we have to address the notion of how many SIRS criteria should you have before you start worrying about severe sepsis. And so let's go with the second question first. My answer is, if a person has an infection, and I know they have an infection, I'm not stopping with SIRS. I'm going all the way to, is there organ dysfunction, before I turn my attention elsewhere. If there's organ dysfunction present, then you can bet your boots that I'm going to be on the bandwagon for getting antibiotics and fluids in as fast as possible. So that's SIRS in general. What about the cutoff of 2 SIRS? Well, as I said, since it's an artificial cutoff anyway, and since most experts would deem that a patient who has infection and organ dysfunction does have severe sepsis, then it probably is almost a moot point. So then we turn to the question, well, what if they just have 1 SIRS criterion when we meet them? Should we call them severe sepsis or not? Well, of course, if they have organ dysfunction, yes, we should call them severe sepsis. And so the question then becomes, should we dump SIRS criteria as something to use at all in the diagnosis of severe sepsis. And that's what this last statement on here is there for, because I think there is a fundamental exercise that lies at the heart of making any diagnosis. And that fundamental exercise is that two human beings have to interact in such a way that the physician human being in that interaction is clued to think of what the ultimate diagnosis might be and to initiate the appropriate diagnostic studies. And this, I think, is the utility of SIRS in the diagnosis of severe sepsis. It's hard to deny that most people with infection get fevers. Most people with infection get tachycardia. Most people with infection get tachypnea. Most people with infection get a high white count. Should we ignore the presence of these physical findings and or laboratory findings and just think, does this person with infection have organ dysfunction? My argument is that it is the very presence of those findings that triggers a doctor or a nurse to start down the pathway that makes the ultimate diagnosis of organ dysfunction and severe sepsis. And I think that is the utility of looking for these simple signs. Roger's whole point when he proposed these was to come up with something that I can see standing at the bedside and very quickly that clues me in to look for this organ dysfunction. And that, I think, is the role of SIRS more than likely in diagnosing severe sepsis, a more important role than whether we use 2 or 0 or 3 criteria. Now, why use 2? Why use 3 to trigger anything? In point of fact, there may not be a perfectly logical reason. And as you've just heard me say, if I saw the patient who was infected, regardless of how many SIRS criteria they have, I would proceed down the diagnostic path. I think what we are dealing with, all of you on here are members of the choir, and you and I are attempting to convert members who aren't members of the choir. And I think in doing so, in using SIRS criteria to help guide them, we are helping them to make more diagnoses of severe sepsis than they would otherwise make. And I think the reason is because they, unlike you and I, are not tuned in to this diagnosis from the get-go and attempting to evaluate every single patient to see whether it's present. That was very long-winded. I had hoped to cut it down and be more succinct, and I will, when I write it down on paper, get it more succinct. But that's my personal estimation of these articles. Anyone have additional comments? I don't know whether anyone has read these articles yet or not. Well, I really seriously would like to hear other people's comments.
Steve?
Yes.
Can you hear me okay? This is Jeff Victor from Minnesota.
Yeah.
From Alina Health, and Lee and I are very good friends. And
oh, yes.
He's not here, and I know Lee really well, so I don't want to speak for him, but I kind of have a sense of what he would say here.
Good.
He's always, the concern he has is those SIRS negative patients that you describe. And first off, you did a wonderful job of that paper, and I really support all of your conclusions. You're right on the mark from my perspective. Lee worries about the patients we're not seeing. He's always worried about not seeing them when they're sick and not catching them until later. And he has an expression he likes to use, the ghost in the room, yes. Meaning that there's something there that we're not seeing. And so I think that he would say the SIRS criteria are just the same way. They're screening criteria. They're tools to help others who don't have the experience that we as critical care and ICU experts do, to recognize these illnesses at an earlier point and understand and know what they are, to start that course of therapy and recognition of illness early on. And I think that that's what he would say. And this comes up for us in Alina Health. We talk about this all the time, and he's always reminding us of this. So, and so I don't know if I'm speaking for him, but I'm certainly speaking for myself in that as well, and what I've learned from him, is that I think that they're really important tools to help people recognize them. And I think that the something I learned from listening to you speak too is the succinct way you described that it's really about infection and organ failure that makes the difference. And I've thought about that really helped my thinking that much more. So I thank you for that.
Oh, fantastic! Thank you. Yeah, that's good, and I like that term, the ghost in the room. I'm going to borrow it. You can tell Lee he can count on hearing it from me again.
That's okay. That's Lee's term. I want to make sure you know that.
Good, fantastic.
So the ghost in the room to ground, is that what it was?
The ghost in the room. That's just what he says. It's the thing that we don't see that's there.
Yeah.
Okay.
Yeah, I like that. The thing that I'll type this down for all of us, don't see that's there. Bingo. Actually, I might, instead of abbreviating, I will say that is there. Coolio. I like that. Yeah, so I think I didn't say this as I was talking, but these folks from ANZICS, and there's a very vocal minority of people who have been arguing against SIRS forever. And I think they've been arguing against a straw man, really. Jean-Louis Vincent, for example, goes, am I going to wait to treat somebody who's in shock just because they don't have SIRS? No. So of what use is SIRS to me? And I think you said it, Jeff, and it's what I was trying to say too, that Jean-Louis Vincent is one of the world's experts at sepsis, and he is looking just like we said, he's looking straight to the organ dysfunction and going, is there an organ dysfunction present here? And I don't care about the SIRS, but he is not the average doctor. And I have such a hard time with my buddies that are like this, tremendous experts. I respect the heck out of Jean-Louis Vincent, but they refuse to understand that the average doctor and the average nurse in the average hospital are not the world's expert on sepsis in one of the top hospitals in Europe looking at the septic patient. There just is a difference. Paula typed us a note to all that she said she agrees that SIRS triggers nurses to alert physicians in community hospitals that patient needs or meets criteria. I love that. I wish I could, let me see if I can copy it, and will it paste? Come on. Yes, perfect. Cut that out of it. Voila. SIRS triggers nurses to alert physicians in community hospitals the patient needs or meets criteria. Oops, looks like I got it twice there. There we go. Cool. I love that. I like this. How do you like this? Updating the PowerPoint. Updating the PowerPoint on the fly, so it will be right here in the thing. And also, if anyone wants this PowerPoint, just email me. Josh, yes, please ask a question about the article.
It looked like, if you go back a couple slides on your presentation, that folks that had met one of the criteria versus 0 had better outcomes. Am I reading that right?
Oh, let's take a look here.
Because if that's the case, then
yes,
that just lines up with what Paula said about how maybe it alerts the physicians and they get care sooner.
Yeah, that could be. That could well be. Yeah, so if you look right here on absolute percentage who died, so the mortality is slightly lower with 1 than it was with 0. Absolutely correct. And you could be right. That chances are, remember that, let's see, what did we say? Tachycardia was the single most prevalent, followed by tachypnea, followed by fever. Or fever or hypothermia. So not quite sure 100% why this mortality is a little bit lower than this overall, although you can see there's a fair amount of scatter here and slightly less scatter here. They may actually overlap statistically. Although,
Thank you.
yeah, although I can't say that for sure. There is a data supplement to this article, and it may actually tell us in the data supplement, but I don't have it pulled up. So rather than taking that time, I'll just tell you, I will look in the data supplement and see if I can tell anything about that. Anything else, folks, about SIRS? Is anyone here going to abandon the use of SIRS in your hospital?
No, not at this point. But I think what you presented was awesome. You did a great job as always, and so I just sent your request to have a copy of the PowerPoint. So wonderful job.
Oh, good. Thank you. Yeah, I'll be glad to send it. And anybody else who wants it, you are welcome to it. That's the nature of this collaborative, is whatever I've got belongs to you. And so I just kind of put this. Unfortunately, Ruth, I didn't have time to put my notes at the bottom of the slides, but I think they're reasonably self-explanatory and can be built on when you want to use them yourself.
This is Kelly Boyer. Also, if you post the recording, I can imagine. I don't know if we could also get the PowerPoint on that page, or if you'd be willing. I don't know. However you choose best to share it.
Well, let's see. How do I do that? Because I post the recordings to YouTube these days. So
sure.
Yeah, so it doesn't have exactly a place. But I tell you what I will do is I will post this PowerPoint with other PowerPoints on the Midwest Critical Care website. How's that?
Thank you.
So I think it'll probably be here. Let me pull this up. It will be on the one that said shared ICU quality improvement files. Yeah, I'll put it down here under teaching slides. That sound okay?
Great.
Okay, perfect. Let's see, and that may not be till tomorrow or something, because I have a jam-packed schedule here today. So let's talk a little bit about some of these other articles. There are about 3 different articles that reinforce one another. There's a 4th one that's an editorial that's written by a friend of mine, Jim O'Brien. Do the detractors of SIRS, before we move on, Bob had a question. Do the detractors of SIRS have an alternative? No. Thank you, Bob, for asking that question. He says, do they have some alternative that they are proposing for what we should look at? And no. And I think the key point that they forget is this is fundamentally a human-to-human interaction. Something has to trigger me as a doctor to think, could this be severe sepsis? And if they were to completely eliminate SIRS as any sort of a criterion, perhaps what they don't like is the term criterion. Maybe they want to say, I don't know, what would be a nice term for should make you think of it, not necessary to make the diagnosis. I'm certain we have a word that would say that, but here, being put on the spot, I can't think of it. But no, they have not proposed alternatives.
Is there an indicator?
An indicator of possible sepsis. I like that.
Right.
Let me go.
That's what we use at Via Christi. It's an indicator, because since we have Cerner, we have the ability in the ED where we're piloting that alert will come up if it's SIRS or if it's sepsis, and then we immediately activate the 3-hour bundle. We have not turned it on for the rest of the hospital, but because of the new 2016 CMS requirements, I think within the next 6 months we probably will turn it on. And we use the word indicator rather than criteria. Yeah,
I like that. I like that a lot. I think I might start using it that way. And in fact, you might find yourself quoted in something that I write here before too long. Actually, you might find yourself plagiarized rather than quoted. So get ready for it. Let's see. Yeah.
It's all okay. It's all good.
Yeah. Yeah, that's an excellent term that I like. An indicator, and maybe I'll go one more and say indicator of possible sepsis. No, possible severe sepsis. So I think what they are indicating, actually, here's the other thing. If you toss out that baby with the bathwater, that SIRS, then what it sounds as if they're suggesting is that one should eliminate the entire category of sepsis from the lexicon. And from what I know about what's underfoot with these consensus conferences around diagnosing severe sepsis, I think I may have said this in one or two of the last couple of months, that the undercurrent and the rumors from the big multi-society conference is that they may be thinking about taking away the term severe sepsis. And they might be moving to say, let's simplify this down to just sepsis or not. And the reason that they might do it is because they feel that after 20 years of attempting to get people to use the term severe sepsis, that it is not happening very well. And maybe they should just get people, that most people are saying sepsis anyway. And so perhaps this is a chink, or not a chink, one of the bricks in that wall. Well, look, SIRS, as we use it, may not be exactly correct. So maybe we shouldn't think about a category that's just infection with SIRS and without organ dysfunction. That's going to remain to be seen. I wasn't invited to any of those consensus conferences. I haven't made my way up the food chain far enough to get to weigh in there. But the thing that I would keep saying to them is what I keep saying here, which is that this is a fundamental human to human exercise that's at the heart of diagnosis of any type, of any disease process or illness. And we can't forget that. Or apparently we can, because they seem to have, but but we should not forget that. So let's, we've only got 15 minutes left. I didn't honestly think it would take us 45 minutes to do the other topic, and that's okay. It doesn't bother me that it did. But there are 3 articles here, and I will hone in on the references here for you. Critical care medicine. 2 of these 3 are in the April issue of Critical Care Medicine. This one happens to be done by a couple of friends of mine, Andy Goodman and Dee Ford at South Carolina. And I think it's kind of funny because what they did was take people who had been hospitalized with severe sepsis or septic shock, figured out whether this was an index admission for them or not, tracked them in the database to determine whether they had been readmitted or not, and so looked at why were people readmitted, how many people were readmitted, etc. Now, what I think was funny about this is that they both live in South Carolina and work at the Medical University of South Carolina, but the database they use is California, Florida, and New York. And they say the reason they use that is because they're really large geographic and population areas. So they thought they would get the best indicator for what's going on nationwide. So for this particular group to identify severe sepsis or septic shock, they use the ICD-9 codes. Now, as you know, they state here in their next sentence, this approach provides a highly specific severe sepsis cohort, which I agree with. My own work supports that it is highly specific. Um, but it's not very sensitive. Remember that over time it is getting better, we think, because of our many efforts to educate people and how to use it, but it isn't terribly sensitive, so we have to keep that in mind. So basically they evaluated this database looking for exactly that. What they saw was there were 2.9 million admissions, 84,000 of them were coded for severe sepsis or septic shock. And when they looked at those 84,000, 43,000 of them would qualify as an index admission, meaning the patient had not been to the hospital in the previous 90 days. So they considered this the principal problem. So I find that of interest because, as we've talked about many times, sepsis or severe sepsis is the commonest cause of readmission for any reason to the hospital. And so what we're saying here is that about half of these people had been in the hospital in the previous 90 days and were being readmitted with severe sepsis, which is an important finding in and of itself. That when they took these 43,400, that they thought this was the index admission, sepsis was the primary problem. They followed them for 180 days. 20,900 of those were readmitted, and 3,600 additional people died. I don't think they told us out of these 43,452. Let me see. Oh, yeah. So I don't think they actually ever say what the mortality rate was. If you took everybody who was admitted to the hospital at the same time, what was the mortality rate and survival rate that qualified these 43,000 to be in the cohort? They never really addressed that issue. So I can skip down through a lot of stuff in this article. Here's another good place. I highlighted this to illustrate the point that I said before. When you start talking about 43,000 survivors in the group, 22,000 who weren't readmitted, 21,000 who were readmitted. You talk about groups that are 20 and 21,000. So the Charlson comorbidity score, which is a score with arbitrary points given for what your underlying disease processes and comorbidities are. So what they showed is a difference at a highly statistically significant level between a 2.79 score and a 3 score here. You know, is there really seriously a lot of difference between a 2.79 and a 3? Clinically significant? I would argue probably not. But with numbers that huge, it's easy to show differences. So age didn't seem to make a huge difference, although, again, there is a statistically significant difference between the readmissions and the no readmissions. Coming down here, I think, is probably the key, some of the key things that we want to see about these patients. So a couple of things. So this shows the cumulative readmissions over time. The bars are cumulative proportion of the initial survivors who have been readmitted at any given time up to 180 days. So the cumulative proportion reached 48%, which is quite substantial. And that's an important fact and probably the key thing to know. As a matter of fact, in the editorial, the editor of Critical Care Medicine wrote at the front of this, he said, these 2 articles that we're publishing this month about this show us that surviving sepsis, surviving to the end of hospitalization, is only the end of the beginning. And he said, and it very well may be the beginning of the end also. So half the people are going to be readmitted in the next 6 months. And then this shows the cumulative proportion of mortality in those who are readmitted. And this I find fascinating. And I've been combing through this article looking for an answer. This is 8% mortality. And if I'm reading them correctly, so they're saying that if you get readmitted, let's see. No, this is 8% of the total cohort we started with. In other words, so if you make it out of the hospital, within 6 months, 8% of you are going to die, even though you made it out of the hospital with your severe sepsis. And then so what do they show? Oh, on the bottom they are showing costs, and I think it's easier to read right here. Severe sepsis survivors were responsible for 13,790 readmissions within 30 days and 43,000 within 180 days. Cumulative cost in 30 days of 360 million and of 1.1 billion. And don't forget, that's a cumulative cost over 6 months, $1.1 billion in 3 states in the United States. Admittedly, 3 large ones, but nevertheless, just 3. What kind of things they looked at, what kinds of things could tell us who's more likely to be readmitted with sepsis or be readmitted to the hospital? And the answer is, not shocking. Medicaid and Medicare give you a higher risk of readmission. Malignancies give you about a 34% increased risk of readmission, but things that we would anticipate: collagen vascular disease, chronic kidney disease, diabetes, a little bit more. The interesting thing is that, let's see, do they say it here? No, they don't say it here. I thought they have maybe down here. Age less than 80, more likely to be admitted to the hospital, and they make the statement that age over 80, they were more likely to have been discharged to hospice than to either home or rehab. So that sort of explains. They don't really say it here, but they're acute here. I underlined it. Acute organ failure was not predictive, meaning that how sick you were with your index case of sepsis is not predictive of whether you're going to be readmitted or not, which I find that both fascinating and disconcerting, because what it means is that the person that we turn around quickly may be just as susceptible to coming back as the person we don't. And we're going to have to rely on looking at other things like the comorbidities of being an oncology patient or having a collagen vascular disease. So that's one. Then published at about the same time, only in JAMA, here is from, I forgot where these folks are from. Let me scroll down and see if they say, Michigan, that's right, Ann Arbor, where they looked at the same thing, basically with a different data set from the Michigan data set, looking what proportion of people were readmitted to the hospital in, now I've been talking 180 days. I think here we're just talking 90 days in this study. Severe sepsis was responsible for a higher proportion of readmissions to the hospital than other age and sex and variously matched reasons for being in the hospital in the first place. And they looked at what they called potentially preventable readmissions, meaning that if people had had the appropriate ambulatory care, could these admissions have been prevented? And they believed that about 40% of the admissions could have been prevented. What did they say? 42% could have been prevented with adequate post-hospital care. So that's what they were after looking at in that study. And then there was one more, again published in April in Critical Care Medicine, looking at use of acute care, ED visits, and hospitalizations within 30 days of discharge after the index hospitalization for septic shock. And they will find, as you can see, I'm sorry if I'm making anyone dizzy scrolling this way, they will see again that there's a high rate of readmission. 37% of these patients were readmitted to the hospital within 90 days, which is kind of comparable to that first study we looked at. If they were discharged with septic shock, 3/4 of the ER admissions and readmissions to the hospital happened within 15 days of discharge. What things were they readmitted for? Infection, likely sepsis again, was almost half. Cardiovascular and thromboembolic disease, about 20%, just under 20%, and then acute kidney failure, etc. So again, I think I will go back to, what patient level factors. Again, they found that oncology was highly statistically significantly associated. The comorbidity index they felt was associated, and the lactate, interestingly enough, the mean lactate was 4.8 in those who had a readmission versus 4.2 in those who didn't. So this was a quick romp through all of these. Last thing, length of stay. The longer you were in the hospital on your index admission, the more likely to be readmitted. So again, a quick romp through all of these. I think it just reinforces kind of what we already knew and what some of you have seen me present before, that the end of that sepsis admission is not the end of all the problems. And I like what Tim Buckman said. It's the end of the beginning, or possibly the beginning of the end for some patients. And so we need to view it that way. What's disconcerting to me about it, again, as I said, is that the acute organ failure index doesn't seem to be predictive of whether you're going to come back, meaning how sick you are when you present to the hospital the first time is not a predictor of whether you're going to come back the second time. And so what that leaves a little bit open for me, it leaves an open door. So all of these things that we are doing to prevent mortality with early antibiotics, with early fluid boluses, with aggressive hemodynamic management, we know that they can save lives. The question remains open whether the earlier we do those things, does it prevent the readmissions? Does it prevent the chronic debility that one gets from an episode of severe sepsis? And I'm afraid I have to say that I want to believe it, but I don't know for a fact that it's true. Questions or comments about those things? I actually do have one more comment, which is this. There is a growing movement towards having post-sepsis clinics and or post-ICU clinics that people can get into quickly to try and head off these readmissions. And I think I support that, endorse it, and I'm making plans in my own pulmonary division for how can we manage to make that happen so that our ICU patients don't have to come back. Anything else? You guys are being quiet now. I've bludgeoned you into submission.
No, you do an awesome job. You're great.
Well, thank you. So our next meeting is going to be June 11th. And it's an even month, so it will be an evening meeting at 6 p.m. I haven't settled in on what to talk about. Anytime you guys have topics you'd like to talk about, either that you would personally like to bring up and talk about, hey, I found this paper and I'd like to bring it up and show it to everybody and talk about it, or anytime you come up with something that you want me to talk about, please just send it, nail me with it, because I'm excited to do all of that. One thing that this has inspired me to do is that I have a good friend, Anand Kumar, in Winnipeg, and you're probably familiar with his papers about antibiotic delays and septic shock and the consequences of those. He gives an outstanding talk about this transition from where you have infection to where you have shock and what it might mean and what's the importance. And I think that talk can shed some light on a lot of these notions about SIRS, no SIRS, about hospital readmissions, how can we, should we intervene, etc. And I'm going to ask him if he would do that for us. The nice thing about us is that we talk via computer and via telephone, which means even if it's an evening talk, he can do it from his study at home, and he does a great job of it. So I will find out in the next 2 or 3 months if I can twist his arm to do that for us.
I think that would be great.
All right, guys. Oh, I apologize. It is 1:03 p.m. and I hate ending meetings late. So I'm going to hastily beat a retreat, say thanks everybody for being on. It was really great, and we'll see you again next month.
All right, thank you.
Aha.
Thank you.
You betcha. Bye-bye.